welcome everybody. Thanks for joining this week's iWiMS MS and COVID-19 call. For those of you who are joining for the first time, the International Women in MS community has started these meetings a couple of weeks ago with the intention to provide a platform for clinicians caring for MS patients that suffer also from COVID-19, to provide a platform for exchange. And these meetings, including today's meetings, are recorded, and we'll post them on our webpage shortly after the call to make them accessible also for people who cannot join the call right now. I'm very excited that we have 7 speakers today. We'll start out with Scott Zamvil and Michael Wilson talking on a little bit on the immune response to COVID-19 and how that is potentially impaired or not impaired by immunomodulatory treatments, and also an update on serologic testing. And then we have 5 representatives from different national registries that are sharing their experience on how MS patients under different DMTs are doing during the infection with COVID-19. So we ask everybody to share 1 to 2 slides and speak about 5 to 7 minutes. And we'll have a brief 2-3 minutes discussion after each talk, and hopefully also at the end a couple of minutes to discuss the different data. Before we start with the first speaker, everybody's going to be muted. So once we get to the questions, I'll ask you to unmute yourself and ask your questions. I also invite you to use the chat button that's on the bottom of your screen, and you can post questions there and I'll pick them up and raise them. And I'll ask the speakers, when it's their turn to speak, to please share their screen and show their slides. If there should be any trouble, we can also have them emailed to me, but usually it should work very well to share your slide. So without further ado, I'm excited to have Professor Scott Zamvil from the University of California, San Francisco speak about immune response to COVID-19 and how DMTs potentially affect or not affect this immune response. Scott, we look forward to your talk.
So AK, is my slide up?
Yes, I see
everybody?
Your slide and I see you. So everybody should.
Then I'm going 7 minutes. Okay, so we pose a question here about MS therapies and COVID-19 in terms of immunity. We would all like to know the answer to many, the questions of, who has been exposed, who develops immunity, to what extent have we blocked immunity, or have we potentiated immune responses in some cases. And I don't have the answers to those. I think this is a good lead in to Michael, who will continue with the antibody testing, because we really are dependent on that. And the work that we are trying to do, and I think that's already been discussed, I wasn't on the earlier meeting, that wasn't our work, but basically is to try and capture all patients, really, and to be able to order a test that has an antibody test to tell us who has been and who hasn't been exposed, and how that influences susceptibility and also disease course. And so here, let's see if my slide will work. Yes, we have a risk for immune suppression with our immunomodulatory therapies. We all know that. Some are worse than others. I can't answer the question on risk of reinfection. We are hearing on the news quite a bit about that, and I think we're going to have to leave that for later. The question is, are certain therapies more predisposed to cause immune suppression and maybe worse and confer greater risk to COVID disease and outcome? Conversely, are there certain ones that may be of benefit? And in this regard, we have to think not just only of immune responses, but also in terms of cytokine responses. And as you know, and you hear about cytokine storm, you hear that certain therapies are being tested with regard to anti-IL-6. There's some thought that Gilenya or the S1P modulators, including siponimod, could be of benefit. I can't answer that, but those are things that are being tested as well. There are other therapies that may also be potentially have some anti-inflammatory effects that could be beneficial. But also don't forget that at least with regard to interferons, they have antiviral activity. And for that reason, those medications do stand out in that potential. And the WHO has, as we know right now, an ongoing trial testing whether the type 1 interferons, alpha, and also beta could have some benefit in studies right now that are, again, that are ongoing. And so when you consider the DMTs and the effects on the immune system, you've got to think cellular and humoral. You can't just think one or the other. And what I'm going to do is we'll take you through a couple of these, just two, really, are two examples. But when we think about different therapies, we think about their effects on immune function, trafficking drugs, which you think of with natalizumab and S1Ps, and those that cause immune depletion or B-cell depletion or BNT. And then we have drugs that obviously affect have anti-proliferative effects. It may also have some antiviral effects indirectly. So I want to just focus on these in just a couple minutes and give you examples, and that is on fingolimod. As an example of a therapy where cellular and humoral immunity is going to be important in terms of susceptibility to viral infections in general, and possibly in terms of COVID-19. Unfortunately, we don't, again, have the data. From what we understand, in countries that are further ahead than we are, in the United States, or at least in California, where you have more data, our understanding is that there's been no pattern that has been demonstrable that says that one therapy is better or worse at this point. But you may actually have more experience from your own countries. Let me point out that the vaccine studies that have been done, so when you think about fingolimod, you always have to think back to the original trials, antiviral effects. We know that it blocks an effect to herpes like varicella, because we had the deaths and transforms at the high dose at the 1.25, not at the 0.5, which was approved. And presumably the same sort of effect with the other S1P modulators that come up is going to occur. This was the vaccine study, and go through one slide on this, or two slides at the most, and you see a block or a reduction in CD4 and CD8s. And it's important to recognize that CCR7 is the receptor that we have for S1Ps, those cells which are central memory and naive, but not effector memories as much. And CD8s are less effective. But again, it's a disconnect because we know we have the viral effects because we've had infections with that. And here, if we look on this slide here and just the pattern, when you look at cells that are viral, that are specific, in this case, vaccine specific for influenza, and you do the vaccine study with the influenza A and B, you actually see that you get spot-forming cells here, which is by ELISA, comes up, and that it's fairly equal, although there's a tendency to believe that there's an effect that's reduced in the fingolimod group. And if you look at antibodies, it's the same thing. So here's the problem in a study like that, is if you do a study, and it's great for pharma to do all these things, and no criticism to them, but they're going to be done with a patient that's just starting therapy or has only been on for 6 months. And somebody who's been on a therapy for much longer is not going to be the same. And so here's an example where you have an effect on cellular immunity and humoral immunity. And we don't know what the effect is if you did the vaccine study in patients who had been on for quite a while. If we think of our B-cell depleters as the other category, we have to remember that there's an effect on CD20, which is not expressed on plasma cells off to the right. We know it's extinguished at the level of plasmablasts. We know that there's a humoral effect of antibody production. That's clear. When we think of HERMS, we think of Olympus, we think of the phase 3 trials. We don't think much of an antibody production at that level in those clinical trials necessarily. However, we all know that we're following antibody levels now. And if we think of it, the B-cell effects, there's function, they act as APCs. And we all know that the benefit that we see, just like in rheumatoid arthritis, precedes the humoral effect. And so there's a cellular and a humoral component. So the question is, what happens in a vaccine study here? And when that's actually been done, and this is Amit and his study here with Genentech, with Roche, and Amit will talk, I'm sure, about some of these things maybe at the later time or another week. But what do you see? You see a reduction in the tetanus titer when it was tested in tetanus vaccine. And that is a major problem that we have, that we can see that there is a reduction here. These patients, at least in this trial, they specified they had to be on the drug for at least 6 months. So they had to have their first course of 2 infusions and out at least 6 months or to their second infusion. What happens when you look at other responses, pneumococcal polysaccharides and a pneumococcal vaccine, where you have a mixture of 23 different ones. And you can see the patients here are reduced in terms of their responses. And really in terms of looking at IgG responses. So always think in terms of an adaptive immune response, just like you think of IgM first and IgM later, you have to think that there's a cellular immune response that occurs initially, which is an adaptive response that leads to a humoral response that is a CD4 dependent response. And the CD8 response that we know is also IL-2 dependent in the adaptive immune response. And then lastly, again, dimethyl fumarate, keep in mind that there's a selective reduction of CD8 cells, which confers some antiviral activity, as we know for JCV, and may have some effect here. And I'm stopping right there. And any questions or anything later on, I'm happy to take. It doesn't answer the question that has been posed yet because we don't have the data that we need for immunity. All right.
Thanks a lot, Scott, for this very concise summary and also for highlighting that we cannot have to look at both arms, the cellular and the humoral immunity, and tying this to the vaccine data that's out there. I think one important thing that you mentioned is that we really don't know or have any data on people that are on immunosuppression for longer. Are there questions for Scott that we can ask immediately? Please.
Can I ask a question?
Yes,
Hi.
go ahead. Hi.
So I just have a question, because now we know that COVID-19 infection basically induce a lot of lymphopenia in the patients. So the characteristic of the infection itself comes with kind of lymphopenia that might be due to activation of monocytes or macrophages. So this specific viral infection paralyzed part of the cell-mediated immune response. And my question is, does it change our approach and how we look at the effect of DMTs in MS patients? Because we already have somehow paralyzed cell-mediated immune response to the virus. And if we paralyze another arm of the immunity, it may be worse.
So that's a great question, and we don't have answers to all of those questions. It's really more than one question in there. And what is the effect on innate immunity? We certainly recognize that with COVID that there is a lymphopenia. We also have to recognize that we're looking in the blood and recognize that there are other compartments as well. We do get an inflammatory response in the lungs and other tissues, obviously. But to what extent innate versus adaptive, I think that's really hard to, for me to say. I don't have those results. I don't know what the effect is on myeloid cells and paralyzing their response, either causing shifts in cytokine production. I think these are all great questions. I think what I would like to know is what happens after we have, with proteins that are being, should be available, and we know that we should have a vaccine at some point as well. Should we be able to test the effects on both innate and adaptive immune responses? I mean, clearly we're not able to do that right now. I would say, if anything, the people that are paralyzed to some extent are us, because we can't do any studies at this point. So I don't have a really good, sound intellectual response to your question.
Thanks a lot, Scott. I think that's a very nice transition to our next speaker, which is Michael Wilson, who's going to give us an update on huge effort to establish a standardized serologic assay. And please post your question as they come up, and we can come back to all the speakers later and follow up on questions that may arise. Thanks again, Scott.
Okay, thanks very much for having me. Are you able to see my screen?
Yes, that's perfect.
Okay, great. Okay, so just 2 slides here. Just a little bit of an introduction on serology, which is really kind of for the first month of this, there were, a huge number of news reports on all the need for PCR testing, and now there's just been a slew of focus on studies discussing the need for antibody testing. The commercial kits that are coming out now are standard ELISAs looking for antibodies to either the spike glycoprotein or nucleocapsid protein of the SARS coronavirus 2. The majority of the assays that I've seen are to spike, but I believe the Abbott test is looking at the N protein. I should have put a link here. There's a group at UCSF and Chan Zuckerberg Biohub that just released a preprint that's going to be in a website that will continue to accumulate new data. And what they're doing is essentially a very large bake-off with every commercial kit that they can get their hands on and comparing the performance of all the commercially available antibody tests and looking for internal consistency across the tests. So I'll make sure to send that link out to people, but it's a really nice and growing resource for the community just to see, because the quality controls on these kits are not great right now. So in addition to just not knowing from one serology test to another exactly how well they do or don't perform, there's some scientific questions that we really don't have a handle on. One is, how long do antibodies last? We know from SARS coronavirus 1, many patients lost protective neutralizing antibodies within 2 years of infection. We don't know, just based on these single protein ELISAs, how many patients are truly going to have protective immunity. That's hopefully it's a significant proportion, but that's really wide open right now. And related to that, we don't know how useful convalescent sera will be for treating acutely infected patients, and we still don't know exactly what immunogens are going to be the most useful in vaccines. So in addition to the work that's going on to develop whole protein or receptor binding domain protein ELISAs, we've been adapting the phage display work that we've done that builds on work that was done at Harvard in the Elledge lab. This VirScan assay using phage display to display peptides that tile across the entire coronavirus proteome, and using phage to express 38 amino acid peptides that overlap each other that tile across the whole proteome, and to let patient sera pull out the most immunogenic peptides. And so we're hoping to get a preprint online about this within the next few days. But this just gives you a flavor of the data that can come out of it. So this is looking at coronavirus phage display in COVID-19 sera relative to peptides that are pulled out by sera from pre-COVID pandemic sera. So the idea is to really see what SARS coronavirus 2 peptides are uniquely enriched by COVID-19 patients relative to the just baseline seroprevalence that we have to seasonal coronaviruses. And so this heat map here, each row is a patient, and each column is pardon me, there's the dog, a coronavirus peptide, and we're looking at basically a unique kind of antigenic fingerprint across patients. And then this coverage map here shows kind of across the patients which regions of the coronavirus proteome are most enriched by COVID-19 sera. And again, not surprisingly, it's in spike and protein. And the hope is to convert some of these highly enriched peptides into a more specific diagnostic serology. I think that's another key feature of the seroprevalence studies that folks are doing now is most populations in which those seroprevalence studies are being done are, the seroprevalence may be 1 or 2 or 3%. And if your ELISA has a 1 or 2% or 5% false positivity rate, then more than half of the patients you get a positive result on will be false positives. And so there's a real need, I think, now to get highly specific assays rather than emphasizing sensitivity. Because to the extent that people will get labeled as being immune based on an antibody test, the last thing we want to do is do that, give someone that false reassurance and encourage, more less socially distant behaviors if they haven't even ever been exposed to the virus. So that's just a quick overview. And I think, in terms of future directions, again, we've isolated 9 peptides that we're hoping are much more specific for SARS coronavirus 2 infection. So hoping that will inform downstream diagnostic tests. I think the other application of this is, again, this kind of top image here of showing a unique antigenic fingerprint for each patient and being able to track that over time and then correlate that with clinical outcomes. So I'll stop there.
Thanks a lot, Michael, for this very nice opinion really on where we stand with serologic testing, and also the first glimpse on a more specific insight into the immune response. Are there questions? I see in the chat that there's a discussion about using convalescence sera. You mentioned this, Michael. Do you want to quickly comment on your experience? I know in Basel we have successfully done this, in Switzerland, specifically in our center. Do you have experience in your patients transferring, bulk and
I know. Yeah, I'm not involved in those studies. I know that the NIH is funding those. I know there are randomized trials. I think UCSF is part of one of them. So those studies are definitely ongoing in the US. We're helping recruit some convalescent patients to donate serum plasma, but I don't have personal experience or anecdotal experience about how well they may or may not be working.
Mm-hmm. There's another question on the topic of lasting protection. Margaret Burnett is asking, do we really believe the antibody level must stay high, or is it likely that the T cell response is still available and then the B cell can ramp up quickly as needed? What's your take on that, or do you have insights into data on these things?
Yeah, it's a great point. I'm sure Scott can comment on this too. I think, yeah, the antibodies aren't the whole story here by any stretch. So I think, yeah, the SARS-1 study, that's a limited picture. All they did was measure protective antibody titers over time. They didn't have to look back at it, but I don't think they looked at T cell responses in those patients after 2 years. So yeah, absolutely, this is one measure of ability to fight the virus.
So I can add a little bit to that and just say, we know that from influenza, when we look at HA and neuraminidase or any of these, proteins there where we've done more work there or in models and things, the T cell immunity can last for quite a long time. The antibody titers sometimes will come down, and then with a secondary or tertiary response, that it jumps up very quickly. I think one of the things that we just don't know at this point, unless Michael, you want to comment on that, is to what extent do we sense when people are making antibodies, are they really neutralizing on the virus? To what extent do we think that it's protective? And that's my question to you.
Yeah, and I think that there's very limited data on that. I think there was that I've seen. There was a study. There's a preprint out of China. I believe it's a medRxiv suggesting that the proportion of patients with neutralizing antibodies is actually quite low. I can't give you an exact number, but it was, I think, around a third. And I think I've heard just anecdotally from people who are working on making neutralizing monoclonal antibodies that they've, in the patients that they've been trying to derive these from, they've had a pretty low hit rate, and that many patients they can't find evidence that they're making neutralizing antibodies. So again, it's very, very preliminary, but I think it just highlights that we can't just assume that if you've mounted a response that it's going to be fully protective.
Well, thanks a lot, Michael. And I think it would be nice maybe if you can even during the call share the link in the chat function. And I would like to just wrap up the talk with one question from summarizing comments from Jen Grace and Cynthia Farinaz. The question, is there a hierarchy among the tests that are currently available in terms of specificity and sensitivity? Is there like a
So I think, I'm going to actually send this to the group right now. So to my knowledge, this is so it's covidtestingproject.org. So I just sent that out. This website is continually being updated. A key part of it though is, so they had 280 patient sera, and they made plates. So all the tests were tested against the exact same set of samples. And what they were able to look for was internal consistency. But what they weren't able to determine was, how these tests perform to some reference gold standard, because there is no gold standard. So this is kind of the state of the art out there. So you can, and they're continuing to contact kind of every company that's making these assays to see if they can get more added in there. So you can, it's a great interactive website. So you can just scroll along on this homepage there, and they have the names of each of the assays that they've tested. And so you could, find out from your local lab, which one they are using, see if it's listed here, and you can see how it performed. And they've broken it down by IgG, IgM, and then they have patient sera from different time points post infection, and you can see how for each assay the sensitivity goes up, the farther out you get from symptom onset. Another caveat here is many of these patients were inpatients. The few samples we've given them from patients who had mild illness, who never went into the hospital, there's an early suggestion that those folks are harder to detect even many days out from infection. So that's kind of another story to be told, is just whether mild infection is going to be relatively insensitively captured on these tests.
Well, thanks again, Michael. If there are more questions, please post them to the chat and we'll get back to them. Our next speaker is Jeff Cohen. As you know, Jeff Cohen is president of IRBs, and he's going to share an update on his experience from the Cleveland Clinic. Jeff, we are looking forward to your experience.
Good. So I was asked, first of all, just to make a couple of comments as president of IRBs. I just wanted to say that one of our priorities over the last couple of years has been to develop partnerships with a number of organizations with similar goals, and we're very actively pursuing a number of projects with iWiMS, both for us to provide some technical and financial support, but also to provide venues for some of the very valuable programs. And I've been attending these video conferences for the last several weeks, and they've been very interesting. So let me try to share my screen now.
Thank you very much.
Okay, is that showing up?
Yes.
Okay. All right, so what I'm going to show is just some very preliminary data. I literally got these data about an hour ago, made these slides about 20 minutes ago. Let me make a couple of disclaimers. So one is that many other people did this work in addition to me. Secondly, there are a number of other centers who are doing very similar work to what I'm going to show, and we're in the process of combining our data with them. So those include Johns Hopkins and ChemCat. And we're in the process of analyzing these data. So I think I showed this slide a couple of weeks ago. This just lists the various data sources that we are collecting at our center. The first one is our clinical registry. This is MS Paths. The second one is data collected from surveys that we're distributing. That's what I'll talk about today. And then we're combining those with a Cleveland Clinic-wide registry that includes everybody tested for COVID-19 in the Cleveland Clinic, which now comprises about 23,000 people. So the data I'm going to present is from these monthly questionnaires we've been distributing. So as of Friday, we had sent out just over 5,200 questionnaires, and we now have 1,005 responses. So there's really nothing surprising on this slide. This is just a tabulation of the people that have responded. So slightly fewer than 1,005 are on here because people that didn't answer the one of the questions were removed from the survey. But this basically reflects our clinic population. But these are the sort of data that we're starting to gather. So these are the comorbidities and other risk factors that have previously been reported for susceptibility to COVID-19 or severity of the infection. And we're really just reproducing what's been seen in other conditions. This in the next couple slides is what I want to focus on. So this is our questionnaires, among other things, address what sort of infection prevention health behaviors are our patients pursuing. And we distinguish sort of three levels of social distancing. So self-isolation being the most stringent, just limiting social contacts or no change. And there's I think some interesting things are starting to emerge. As shown here on this very complex slide is that there's several factors that even with our relatively small numbers are starting to emerge. So first of all, disease duration. So people with longer disease duration are practicing more stringent social distancing. People with more education are practicing more stringent social isolation. And then people with better area deprivation index, which is a measure of socioeconomic disadvantage, are practicing better or more stringent social deprivation. The other way of looking at it is that people with a higher ADI, many of those people are forced to continue working. They can't just stay at home. The other issue that I want to just highlight is this, which is something that I think we all suspect, which is that people are altering their MS management as a function of the COVID-19 pandemic. So almost just over 15% have had interruption of rehabilitation or a lower percentage of home care services. A certain number are changing their DMT, and only about half of those are doing that because they were advised to do that. About half of our patients are making changes. Of the patients that are making changes in their DMT, about half of them are doing it unilaterally. So these data that I showed you are just starting to emerge. We're just starting to analyze them now. But I think as we get more confidence and combine our data with those of other centers, we'll have some interesting observations. So let me see, where can I'm looking for the stop saving.
Thanks a lot, Jeff, for the update and insight. And I think it's actually highlighting that we're probably going to face changes beyond COVID-19 infections, such as you highlighted, that is patients that are not affected by the virus, but independently interrupting their treatment and also being impaired in rehabilitation processes. So I think that's something that we'll have to face well past the pandemic. Are there questions for Jeff right now?
Yeah, I don't see any. So I'll answer questions later if some come in.
Yeah, so thanks again. We'll move to the next speaker, and please use the chat to ask questions. I'm excited to announce the next speaker from the US, and that is Anne Cross, giving us an update from the MS Center at WashU. And please share your slides.
Can you see the slide?
Not yet.
Uh-oh, okay, let's see if I can figure out. Haven't done this before.
No worries.
So.
If you go on the bottom, press share screen, then it should.
Yeah, don't see a shared screen here. I've seen it before. How many over is it? Amber, are you on?
It's on the bottom. It's like a little green square next to where it says invite.
Okay. I see the green square. Yeah. So maybe.
And then you choose the screen you want to share.
Right. Okay. So that could be challenging. Let's see if this was. That's not it. That's not it. That's not it. Okay.
Perfect. Yeah.
That's not it. All right.
Ah, that's the wrong. That's your email.
Okay. Sorry.
No, but
let me try this.
Mm-hmm.
Do you see anything like a slide there? No.
No, but maybe you just basically unshare your screen and then share it again, choosing the PowerPoint.
Okay.
Try it once more.
And you can close your email. Close your email.
How about this one?
Perfect. Yeah.
You see it? Okay.
Yes.
So this is, well, thank you for inviting me to speak. I'm happy to be here. And like Jeff, I'm presenting the work of many different people. This is a project that the National MS Society and the Consortium of MS Centers collaboratively put together. And then the Canadian MS Society is also working on it. It's called COVIMS.org, and it's a North American registry of cases of MS. Also, we have a few neuromyelitis optica and MOG antibody disease cases, but primarily MS, people who have had COVID-19 and what happened to them. And everything is de-identified, and we've asked clinicians, this is a clinician registry, to only input data after it's clear what's going to happen to the patient. So after a minimum of 7 days, and preferably after resolution of disease, so they'll know what happened. So, and we had two major questions. How do MS patients fare when they get this disease? And is there any impact of individual disease modifying therapies? So here's data. This is data. The registry was put together by Dr. Amber Salter. And she's on the call, so she can probably answer questions too. As you can see, we've had 120 total cases as of this morning have been reported. Most of those by far are MS, but we do have 2 NMO and 2 MOG antibody disorder cases. And our racial makeup is down below with almost 60% white, 23.5% Black or African American, and 11.8% Hispanic, and a number of people who are either other or unknown. So this is North America. And then from now on, I'm just going to talk about the MS cases. So there are 116 MS cases as of this morning. And as you can see on the left-hand side, close to 80% are relapsing remitting, 16% secondary progressive, 3 to 4% primary progressive, and most of them, over 85%, were on disease-modifying therapy when they got the disease. And over 75%, 78.4% of patients were confirmed positive with laboratory positive, and then there's another slightly over 20% who are suspected but not laboratory confirmed in our group. And again, we're talking about just the MS patients here. 26.7% were hospitalized, 5% ICU admission, 5% ventilators, and 2.6%, that is 3 only, deaths so far, which is great. And then here's a little bit more granular data comparing those total cases in the middle to those that died, the 3 MS patients that have died. Those 3 MS patients were all male, whereas our total cases were predominantly, of the MS alone, were predominantly female, as you might expect. Mean age of those that died was 59, so a good 10 years older than the total cases. The ones that died were all men, as I mentioned, and they were all white. Their disease duration was a little bit shorter on average than that of the total cases, suggesting perhaps that they were more aggressive. Their clinical course, they were all progressive. Primary progressive, 1 case, and these are the ones that died, and 2 secondary progressive among those 3 that died. They were all either needing assistance to walk or were non-ambulatory. So 2 walked with assistance, 1 was non-ambulatory, compared to above that in the total cases, most people were ambulatory, 69%. In the disease-modifying therapies, which it seems like everybody is interested in this, the people that died, there were 3 men, as I mentioned. 1 was on dimethyl fumarate, 1 was on ocrelizumab, and 1 was on nothing, no DMT. And of those 3 people, 2 of them had known comorbidities. 2 of them had hypertension, but I think they had other comorbidities as well. And then those are the percentages that were hospitalized and in the ICU, according to what we know about these 3 people, compared to the total group of MS cases. We also, by the way, had 1 case who was confirmed positive laboratory-wise and was asymptomatic. I don't know what that patient was taking, but that patient was put into the registry as well. And then this is my final slide. It's a list of the various disease-modifying therapies that people on MS were taking, were listed as taking at the time they got COVID-19. And so, as you can see, there were 2 out of the 116 on alemtuzumab, 14 on dimethyl fumarate, 9 on fingolimod, 4 on glatiramer, 3 on beta interferon, 11 natalizumab, 38 ocrelizumab, 7 rituximab, 9 teriflunomide, 17 on nothing, and 2 on something else. So I'm going to walk over to my phone and pick that up and hang it up, or it'll ring. That's my dog. So that's our data. I'm happy to answer questions if you have any.
Thanks a lot, Anne, also for this very detailed stratification within these patients. Are there immediate questions?
This is Susan Gels, and I had a quick question. On this last table, it would be interesting to look at this in people who are over, let's say, 55 or something like that, to understand the people who are most at risk, what therapies they're on.
Uh-huh. That I do not know. Amber Salter's on here, and she could certainly do that. She's the person who put together all this data and actually gave it to me this morning to put into slides. So she may know. I also want to encourage everybody in North America on this call who has cases, please, please, please put them in so we can get as many North American cases of COVID as possible in here. We don't have denominators, that's clear. We don't know how many people are on each of these drugs. I'm told, don't know for certain, that ocrelizumab is has the largest market share at least in the United States, and fingolimod is number 2, is what I've been told.
Thanks
So
a lot.
I have a question. This is Rhonda. Great presentation, Anne. That's really interesting. So in Italy, men certainly died more often than women did in non-MS. And then I think some of the data in New York has shown the same thing, that men are doing worse once they get it than women are. So the fact that 3 males died when 75% of the population was female, it indicates possibly, but you know, 3 isn't as extremely low in. So my question is, have you looked at, for example, percent being put on a ventilator? So not death, but something that indicates worse disease that's not necessarily death, where you can get a bigger sample
And so
size.
what you're asking is
female,
by gender, right? By sex?
Yeah.
Yeah. We should have those data. We didn't parse it out like that. Again, I think Amber could probably figure that out from the data we have, but we didn't parse it out in that way yet. So thank you for that.
Yeah, this is Amber. We can definitely add it in for next time if people are interested in looking at that.
Wonderful. Thank you. Thanks again. We'll move to the next speaker, and that's going to be Kate Fitzgerald from Johns Hopkins. Kate, are you on the call?
Yes, I'm here. Hi. All right. So I'm going to be presenting some of the information from a registry we started at Johns Hopkins, which is very similar to the one ongoing at the Cleveland Clinic. So as a Cleveland Clinic, our registry is patient-centered. It includes adults with MS as well as other people with other autoimmune or inflammatory conditions. The conditions included are right here, as well as the top 10 conditions for people we invited to participate. This includes a weekly survey asking questions about demographics, disease-modifying therapy, concomitant medications, social distancing and employment characteristics during the epidemic, as well as comorbidities. We have plans to link with an existing biorepository, and so this is just data from the first from the first week of data collection for ours. We invited 1,574 people with MS to participate. So far, 517 have completed the survey. We're set to set our second round of invitations to be sent this week to all eligible participants. And on the right-hand side is a table of just descriptive characteristics for people included, for people with MS, as well as other conditions. The average age for the population here was around 49. We have a decent number of male participants, as well as describing different comorbidities, as well as different characteristics like smoking or use of e-cigarettes. This is the breakdown of the MS DMTs and DMT usage in the participants who have replied to the survey already, similar to kind of what the data has been presented so far. These are the breakdown of different DMT classes, as well as changes to DMTs that have occurred since the COVID epidemic. We also inquire about specific concomitant other medications that participants may be using. In addition, we also collected information on other immune modulating medications, which are described here. Some of the most common ones are described here for people with MS, as well as other autoimmune or inflammatory conditions. With respect to COVID testing and symptoms, only 10 participants report having been tested for COVID-19. None of the MS patients report positive COVID results. However, around 13% report at least one viral symptom, and the distribution of the different viral symptoms are reported for people with MS here, as well as other autoimmune and inflammatory conditions. We also asked questions about household contacts with known COVID-19 exposures, as well as the work history and employment characteristics of people with MS, as well as their household contacts. In addition, we have the social distancing characteristics. So similar to the distribution, I think that was presented in Cleveland Clinic, most of the participants are self-isolating and socializing virtually. However, a specific group of people are still socializing in person and going to public places. And we have plans to similarly look at potential risk factors or predictors of social distancing practices. And that's all I have for now.
Thank you very much for this comprehensive presentation on the questionnaire. Are there urgent questions? If not, I would propose in the interest of time to move on. Our next speaker is Nikos Evangilou from the United Kingdom. Nikos, we look forward to your experience. Are you?
Hi, yeah, thanks. Perfect. Yes, I'm here, I think. I hope you can see it. Can you see my slide? Yes. So this is the work that we have done with the UK MS register, Richard, Nicholas, and myself leading the project. So we have had very, very similar experience with what other people have described. So we have asked a neurologist in the country to report any cases, and so far, 36 cases have been reported. You can see that the ratio of males and females are very, very similar. And out of those, 27 were confirmed with PCR. And we had 4 deaths, two males and 2 females. And you can see the age, and only one of them was on a disease-modifying therapy on interferon. But we don't think that this captured the effect of COVID on the MS population. So we have used the MS registry. And the MS registry has been operating in the UK for a long time. Richard has presented previously some of the results. And every couple of weeks, we send a questionnaire, and essentially we say, have you had any new illness? Have you had a respiratory infection? If they say that I have had a new chest infection, then we go in much more detail, try to find out exactly what it is. And then if they said, no, I'm all right, then we say, that's okay, we'll send you another questionnaire in 2 weeks' time. And this carries on. So this is the results of so far. So this is still a recruiting study. So we have almost 4,000 people that have participated in the baseline questionnaire. And 1,800, you can see here, they have already responded on the second questionnaire, and we keep recruiting. And the question that we have, all of us, we have been facing, and we described is, who has COVID? The people with the PCR positive, the people that have the WHO criteria, the people that they know that they have had it because they have a very bad cold with aching and so on. And on top of that, we are using people in London. They have done a very nice app, and they have asked lots of people, a few million of people, whether they have had symptoms, and they have looked at the people that they have had a positive PCR, so they calculated the predictive value of the various symptoms. So we have a number of different ways of looking at who might have had COVID. And so we can do the analysis, and we can see if any results that we find is replicated on the other results. And this is interesting. I'm sure that lots of European and American colleagues will say, what are you doing there in the UK? So out of the UK MS register, out of the 4,000 people that have answered on our surveys, half of them are not on any medication. And because some of them, they have second and progressive MS, they have for a long time. And this is the number of medications they have reported. So what is the conclusion so far? Essentially, what we are saying, have you had an infection? Have you had COVID over the previous 2 weeks? And we have found that younger people are more likely to experience a COVID infection. Whether you look at the symptoms, whether you look at the PCR, whether you look at anything, the result is compatible. And it's somehow understandable because they are the one most likely to go out and work and less likely to be scared and isolate themselves. But we also looked at, so far, admittedly, it's the first of the analysis, we found that the risk of getting an infection that is either confirmed with PCR or not, is it affected by the disease-modifying therapy? And we haven't found so far that a disease-modifying therapy increases the risk of getting COVID. So that's it. So obviously, we have another branch of, we have healthy controls that we're going to compare. So hopefully we'll be able to find whether patients with multiple sclerosis have more risk compared to other controls, and we're following a number of other studies, but I think this is what I would like to share. That's it.
Thank you very much. We were planning to have 2 more speakers, but I think since we're at the top of the hours, Nikrike and Farinaz, Safavi, if you agree, we would have you scheduled for next week's call.
Yeah, that's absolutely fine.
We can probably take one more call.
Take one more?
Yeah, last time we left late, so.
Oh. So, Farinaz and Nick, who wants to go? Do you have a preference?
Farina.
Hi, either way is fine with me.
All right, so Farina, we really look forward to having you share your experience from Iran.
Yeah, let me just share my screen.
Thank you.
And can you see? Can you see? Can you see the slides?
Yes.
Yes.
Yeah, perfect. Okay, hi everyone. First of all, I would like to give us the opportunity to present this information. At the same time, I would like to say that I'm just presenting on behalf of Dr. Azibi, who's a faculty member in Tehran University, and I would like to thank Dr. Nourbakhsh, who helped us a lot during the course of this project. This is a survey cross-sectional study at the very beginning of the epidemic of COVID-19 in Iran. And at that time, many people didn't know a lot of detailed information about this pandemic, but we tried our best to gather as much information as possible. So just as a background, and you see here, the first cases of COVID-19 were announced officially on February 19. And we sent the survey to our MS patient through an online portal system on March 26. 1,245 patients received the survey and 712 completed and returned it to us during the course of 1 week that we gave for the returning the survey. And I am going to talk about what the data elements we put in that surveys and some information we got from that survey. So that we ask about all demographical features from the patient, age, sex, type of MS, PDDS, current DMTs, and the treatment duration. Also, on the second part of the survey, we ask about the symptoms that kind of consistent with the COVID. The same problem as in many other countries at the beginning of the pandemic, the PCR testing were not available broadly everywhere. And we just ask about those cardinal symptoms of fever, cough, shortness of breath, and some non-specific symptoms. And we ask about recent contact with a COVID-19 patient or if it's someone with the respiratory symptoms, and what happened to those patients. Did they stay at home, presented to hospital, got admitted to the hospital. So I'm gonna tell you a little bit about what we got. As I mentioned, 712 patients completed the survey for us, and after receiving the result, we basically defined the COVID-19 suspected group as a patients with fever and cough, fever and shortness of breath, or any symptoms who underwent chest CT with a chest CT or PCR consistent with COVID. And we also categorize our DMTs to non-lymphocyte depleting DMTs because we did not have any patient on cladribine or alemtuzumab, B-cell depleting antibodies, and no DMTs. As you see here, 34 out of 712 patients fulfilled our criteria for COVID-19 suspect group. 20 of them didn't even present to the healthcare provider. They just called, and some of them mentioned that they were even scared to go out to expose themselves more. Out of that 14 patients who presented to healthcare providers, just 2 of them got admitted in a hospital, and no ICU or intubation or death reported from this kind of survey, with its own limitation, of course. And I just summarized some of the information here. As you see, when we did the univariable and multivariable statistical analysis, when you look at the differences, basically there was no significant difference in terms of the demographical features of the patients. And I want to mention that this patient population, our patient population, were very young. The average age was 35 plus minus 8 years. And 80% of the patients had relapsing remitting. The disease duration were not that high either, and PDDS were very good, around 85, 90% were less than 4. But when we perform a multivariable analysis, we found that the patients who were on B-cell depleting antibodies are significantly higher in our COVID suspect patients compared to patients who are on no DMTs or non-lymphocyte depleting antibodies. And the other variable we found significantly different was the exposure with someone with the symptoms. So I know this is very preliminary data. We need accurately design studies to answer this question, but at the same time, it can give us some snapshot about how MS patients do during the COVID epidemic, or how DMTs may correlate with the patient, with the severity of the disease or the course of the disease. If I can go to the next slide. I just wanted to say that, however, we need to be very cautious about interpreting this data. Our results suggest that the course of infection in MS patients suspected of having COVID-19 mostly was mild to moderate, and all patients in our study fully recovered, and B-cell depleting antibodies may increase the susceptibility to contract COVID-19. That's all. Thank you very much.
Thank you very much for sharing the data. I think if there are no urgent questions, at this point we would close the call. I would like to thank all the presenters for sharing their insights and their data and their excellent presentations. I think that was a very exciting session, and I think it's reassuring to see that across all the studies that we have been seeing and also the data today, there really seem to be no really alarming signals on MS patient under various DMTs. And I also wanted to use the opportunity to highlight a paper that was published today in Lancet Neurology by the Italian group led by Maria Pia Somani of the large MS cohorts. So I'll invite you to check that out. And also more than 200 patients in Italy, they didn't see any signals. So I think that's very encouraging. I think what we learned today also is that there might be a higher risk for male MS patients to be more severely affected. So that's maybe something we would want to continue. And I think Jeff very nicely pointed out that there are non-COVID related changes that patients do in terms of delaying or stopping their therapy independently that we might have to watch out for. So I would like to thank again all the speakers, and I already invite you for the next call next week, which will be chaired by Georgina. And specifically, I'd like to thank Nick again for willing to postpone his presentation to next week. So Nick, will start out with you. Thanks again, stay safe, and looking forward to seeing you next week. Bye.